Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. If this is the first time you're watching one of my procedures, please do feel free to like, share, comment and subscribe if you're on YouTube, or like and follow the page if you're on Facebook or Instagram. We have a client who attended with very medial, so when we say medial we mean close to the eardrum. And when we say lateral, that's the opposite, so it's further away from the eardrum, near the ear canal entrance. So medial, occluding, so occluding means when it's sealing the ear canal, dead skin or keratin. The patient is prone to suffering from otitis externa. So otitis externa is an umbrella term for an infection or inflammation or soreness and itchiness of the external ear canal. They recently suffered from, we call that otitis externa, as I said, and she recently was prescribed some antibiotic ear drops from the GP. And although the otitis externa had improved, the patient still felt blocked and they had this residual dead skin. So this dead skin actually has shedded and migrated off the eardrum, but it's got trapped very deep in the ear. It's no longer migrating. So the entire ear canal and the outer layer of the eardrum, so the eardrum is composed of 3 layers, and the outermost layer, so the lateral layer, is actually the same skin that lines the inner 2/3 of the ear canal. So it's a very delicate sheet of skin. You're approximately 0.1 millimeters in thickness. And as that skin dies off the eardrum and the ear canal, it sheds and moves and migrates sideways, laterally, out of the ear like a conveyor belt. You can almost think about it like a snake skin. Now, if the ear didn't have that ability to shed skin in the way I've just described, everyone's ears would be blocked full of dead skin. So imagine you've got dead skin on your hand, and as it dies and sheds, it just falls onto the floor. If the skin just fell into the ear canal, and as I said, everyone's ears would be blocked full of dead skin, that skin will get infected and it can cause a whole host of problems. So the ear over the millennia has evolved to naturally shed the skin in the way we describe, in a conveyor belt motion. Now with this patient, this skin, it just gets, as it sheds, it does shed and it migrates outwards slightly, but it gets trapped very deep in the ear, probably a centimetre away from the eardrum. And it's this dead skin, I feel, that then gets infected and causes otitis externa. So it's very important for me today to try and remove as much dead skin, keratin, as possible. Now this skin is going to come back, it's a chronic problem, but if the patient attends regularly enough, and if I can remove the skin, dead skin, before it gets infected, at least she doesn't suffer from otitis externa. So we're using a fine end gauge attached to a standard ulnar suction probe. The fine end is much better for precision procedures or delicate procedures when I need that fine motor control. So it's imperative for this procedure to hold the suction probe correctly. If you follow me on LinkedIn or on Facebook, you would have seen that I did a quick video yesterday explaining how an ear care specialist should hold a suction probe. And I've seen many different ways of people holding it, but essentially you should be holding it like a pen or a dart, so your finger and thumb either side on the handle. Seen people be holding the ulnar suction probe via the tubing that connects to the ulnar suction probe. And if you're holding it by the tubing, well, you shouldn't really be holding it there, and you lose all this fine motor control. So this is a great video to illustrate the importance of a correct grip when you're holding the suction probe. And it also really illustrates the real benefits of endoscopic earwax removal. So with an endoscope, we can see the entire ear canal. So it enables me to manipulate this dead skin right off the ear canal wall, all the way around the perimeter. And remember, we're on the bony part of the ear canal. We've got to be so gentle. Don't want to be making contact with the bony part of the ear canal because it's so sensitive. Now you can see the occlusion, the main body of that dead skin has actually been removed, but we've got this kind of undercover layer of dead skin which is almost camouflaged onto the ear canal wall, but just on the base of the ear canal there is another layer of dead skin that's Crusted. You would have seen at the beginning of the procedure I used some olive oil earwax drops to soften this skin because it was quite hard and crusted. Now, I probably wouldn't have attempted this when I first started performing earwax removal, but because it's just such a tricky and delicate and precise procedure, I would have probably just left this. But as I said, I'm not removing this dead skin to try and improve the patient's hearing. The hearing has already been improved, but it's more of a preventative measure to stop the patient developing otitis externa, because this skin is unfortunately not going to migrate any further. Fortunately for this patient, this dead skin just stops migrating. Where the ear canal narrows, you can probably see this ear canal narrows and it widens back out, and that's called an isthmus. We all have a narrowing. We have two narrowings in the ear canal. We have two bends. The first bend is about 1/2 centimetre into the ear canal, and the second bend is 1 centimetre into the ear canal, and that's when the bony part and the cartilaginous part of the portion of the ear canal meet. It's called the osseo-cartilaginous juncture, and the ear canal also narrows at that second bend. So that's about 1 centimetre into the ear canal. And you've got a further narrowing about 1/2 centimetre away from the eardrum. So I've just got this final bit of keratin that I'm just peeling backwards now, coming away from the ear and coming more lateral as I'm peeling it. And it's very hard to distinguish this dead skin. It's very difficult. It could have gone easily unnoticed. Now, there's still a bit left on the anterior canal wall. I don't think I managed to get this, so I got that piece there. There is a slight bit left, but it was quite stubborn, and I did try my best, but it just wasn't going to come away. You can see it there. I'm just peeling it away gently. And again, I've just got to avoid the bony part of the ear canal. It's like that game, Operation. I don't know if you, in the UK at least, we had this game called Operation where it's different parts. So it's like a board game, and sort of a human body, and it had different parts, so the limbs, the brain, the heart, and it had a metal perimeter, and you have to use different instruments to remove the different parts, the different organs from this body, and if you made contact with the side, it'll buzz, or you'll have a siren. So this is like a game of Operation. It's kind of really, really gentle. Now, if this patient was asleep, or we anaesthetised the patient, which we don't do, you can, yeah, it's not going to be as uncomfortable if you make contact with the bony part, but obviously when the patient's unanesthetised, we're going to be very, very careful. There's all that dead skin coating on a tissue. I hope you enjoyed that video, guys, and it's informative, and I hope you're all having a wonderful evening, afternoon, or morning, whenever you're watching this procedure. Take care, guys. Bye.